Knowing when to give vaccines is key, and immunization schedules keep them on track. You have already been introduced to some common abbreviations used for vaccines. Over the next two sections, you will see many more. It is probably a good idea, if you haven't already done so, to press pause and print off the vaccine abbreviation information sheet for you to reference during the remainder of this presentation. It is located in the resources section of our site. In addition to the standard CDC age-based and catch-up schedules, the Immunization Action Coalition, which is supported by the CDC, has recommendation summary pages for children and adults. These are designed to be a one-page quick reference for immunization. For each vaccine, the page lists the route to use, standard ages and spacing, catch-up spacing, and contraindications and precautions. Summary pages can be downloaded from the Immunization Action Coalition website at immunize.org. In addition to summary pages, SIIS, the statewide registry for immunizations in Ohio, makes scheduling easier to see when vaccines are due. SIIS has a feature that shows a child's vaccinations together with the ACIP recommended schedule. SIIS also has an algorithm that checks doses to see if they were spaced correctly and given at the correct age. It will notify the clinician if a dose is due or if a dose should not be counted. It is important to note that the SIIS algorithm should be used as a quick reference only. You should always refer to the ACIP recommendation for final decision on determining if vaccines are due. However, despite our best efforts, kids sometimes don't get their recommended vaccines when they should. If a child falls behind on vaccines, an accelerated schedule is recommended to catch them up for their age. Vaccines are given at the minimum intervals to catch them up. For combination vaccines, the minimum interval is determined by the component that has the longest minimum. For example, hepatitis B has minimum intervals of 4 weeks followed by 12 weeks. So vaccine could be given now, then in 1 month, then at the 4th month. This can be useful when getting someone ready to travel abroad, but the accelerated schedule has not been tested for individuals more than 40 years old. And this brings up the subject of age eligibility, which can be confusing with vaccines. There are two sources for eligibility information. When vaccines are first licensed, they get age restrictions from the FDA. Later, however, they get age recommendations from the Advisory Committee on Immunization Practices, ACIP. Sometimes these age ranges don't agree. The FDA limits are based on the research done before licensure. They are the legal limits of vaccine usage, and so pharmacy companies can't advertise uses outside the FDA limits. Providers are allowed to use vaccines off-label because the FDA doesn't regulate medical practices. Once a vaccine is in use, a group of experts at ACIP will make recommendations about vaccine policy. The ACIP recommendations are based on current clinical information and are considered the best way to give vaccines. The CDC guidance comes from ACIP recommendations. There are two kinds of minimums to consider when scheduling vaccines: minimum age and minimum interval. Some doses can't be given prior to a certain minimum age. Some doses must have a minimum amount of time between the previous dose and the current dose. It is not uncommon to have to repeat a dose that is given too early. The Ask the Experts page at immunize.org has specific information about when a dose that was given too early can be counted. We'll get back to the Ask the Experts page a little later in our program. It's important to note that immunization series don't need to be restarted no matter how long it's been since the last dose. You never restart a series if the initial dose was a valid dose. The concern commonly comes up with hepatitis B for employment. If a patient got their first dose 10 years ago, they can get their second dose today because it's been more than 8 weeks since their first dose. The final dose can be given in 2 months, since that meets the minimum interval between the second and third dose. Doses previously given to a patient never expire, so a series should just be picked up where it was left off. The ACIP also has designated grace periods for the minimums on vaccines. However, grace periods are only for checking previous doses to see if they count. The grace period is 4 days. Vaccines given 4 days early or less can be counted. Vaccines given 5 days early or more don't count. Some vaccines can't use the grace periods. The exceptions are rabies vaccine and any live vaccine. Doses that don't count must be repeated. If a dose needs to be repeated, it should be spaced from the last dose, even if that dose wasn't counted. Sometimes this can cause a long delay in finishing a series. For example, if the last Dtap is given before the 4th birthday, it needs to be repeated. The minimum interval for the last dose of Dtap is 6 months, so this means the final dose will have to be scheduled for 6 months after the dose that was given too early. Please remember, do not schedule a child to get vaccines in the grace period. The 2 most important things your clinic can do to make sure all patients are protected are reminder and recall. MOBI, also known as the Maximizing Office-Based Immunization Practices Program, considers this the single most effective way to improve immunization rates in a practice. Call the parent before an upcoming visit to remind them of the appointment. If the parent misses the appointment, recall them to set up another appointment. Some practices use automatic robocall systems, text messages, or email to make it easier to remind parents of upcoming visits. For recalling after a missed visit, a personal call from a staff member is generally considered most effective. Now that we've talked about vaccination schedules and timing, let's examine some issues that only apply to certain vaccines. Let's look briefly at these unique vaccines and their special considerations. The MMR varicella combination vaccine has a subtle recommendation with regard to age. Studies after the licensure of the vaccine revealed a small increase in febrile seizures when given to 1-year-old children instead of separate MMR and varicella vaccines. For every 2,300 doses given, there is 1 extra febrile seizure if MMRV is used instead of separate vaccines. Generally, the ACIP recommends combination vaccines to minimize pain and maximize adherence to the vaccine schedule. The ACIP has said that either kind of vaccine, combination or separate, can be given for the first and second doses of MMR and varicella. But for the first dose of MMRV at 12 months of age, because of the increase in febrile seizures, parents should be advised of the increased risk. Unless the parent prefers MMRV, the ACIP recommends using separate vaccines for 1-year-olds. For the second dose at 4 years of age, there is less risk of febrile seizure, and the MMRV combination is preferred. If anyone in the family has had a seizure for any reason, this is a precaution for the use of combination MMRV vaccine, and the provider should consider the use of separate vaccines. There are 3 common Dtap combination vaccines. The first 2, which include the Dtap Polio and hepatitis B combination vaccine, and the Dtap Polio and Hib combination vaccine, are the most inclusive combination vaccines. The third is the Dtap Polio combination vaccine. Each one has different limitations. The Dtap Polio and hepatitis B combination vaccine is better for an older child who needs to catch up on the first 3 primary doses. It can be used through age 6, but can't be used for booster vaccines. The Dtap Polio and Hib combination vaccine is better for a younger child who needs either primary or booster vaccines. Its age range is limited by the Hib vaccine, which can only be used until the 5th birthday. The Dtap Polio combination vaccine is only licensed for use as the 5th Dtap and 4th doses of polio. As a result, if a child missed a dose of Dtap and is getting their 4th and final Dtap and 4th polio, This combination vaccine is technically not approved for that use, and it would be off-label. The Hib vaccine has a very specific age limitation. It cannot be given before 6 weeks of age because there is evidence that giving the vaccine before 6 weeks of age can prevent the child from making proper immunity to Hib germs in the future. There are 2 types of Hib vaccine on the market now. PRP-T-Hib needs a series of 3 doses plus a booster. PRP-OMP Hib vaccine only requires 2 primary doses plus a final booster for a complete series. Additionally, the polio schedule was changed a few years ago to harmonize with the Dtap schedule. For Dtap and polio, the last dose must be after age 4 and at least 6 months after the last dose. These criteria must be met for the final vaccination to be given, regardless of whether the child is getting 3, 4, 5, or more doses in total. This change was made for polio in the fall of 2009, but is not retroactive. Final polio doses given prior to that time don't need to be repeated if they don't meet these minimums. In recent years, there have been a few vaccines with new developments. PCV13 came online in 2010. Children who started their series with PCV7 can get a booster dose with PCV13 as long as they are under age 5, even if they already had all of their PCV7 doses. Children who are 60 to 71 months of age with underlying medical conditions who started the series with PCV7 may also be given a booster dose of PCV13. Tdap also has been recommended for off-label use by the ACIP to help control pertussis. Children ages 7 to 11 should get 1 Tdap dose if they did not previously complete a pertussis series. If they already had a complete series, they can wait until the 11-year-old booster for Tdap. Additionally, MCV meningococcal vaccines have been recommended for a booster at age 16 to 18 if the primary dose was given prior to age 16.